All right, so it is just past 3 o'clock Eastern or 2 o'clock Central, so we will get started. Hi, everyone, and welcome to March's Better Breathers Network program on women's respiratory health. My name is Nicole Goldsboro, and I'm the National Manager of Lung Disease Programs for the American Lung Association, and I will also serve as your moderator for today. Before we get started with Dr. Han's presentation, I just wanted to review some housekeeping items as we get started. So as a reminder, we will just ask that your video is off and you are just on mute during today's presentation. It will also be recorded. So if you are interested in listening to the recording, you can actually just use the same link that you used to register and that you received during your registration to listen to the recording. At the end of today's presentation, we will offer Q&A. And you can use the Q&A two different ways. The first way is that you can use the chat feature that's at the top of your screen, and then you'll be able to ask any questions through the chat box. The other way is that you can ask your questions by raising your hand, and that's also available at the top of your screen. And that will just let us know you have a question, and then at the end we can do that through the Q&A. The other thing is that at the very end, I will ask if you complete a really brief survey. We would love to hear from you and learn what you liked about today's webcast, as well as we would love to learn what you want to see in the future. So please take just a few minutes and provide your much valued feedback. So let's talk a little bit about the American Lung Association before we get started with today's presentation. Today's presentation is offered through the Better Breathers Network. And if you are not a current member, at the very end, we'll talk about how you can become more involved in this valuable resource provided through the American Lung Association. The American Lung Association, the vision of it is a world free of lung disease. And for more than 115 years, the American Lung Association has been a champion for lung health with our mission to save lives by improving lung health and preventing lung disease. And we achieve our mission every day through education, advocacy, and research. Our work includes efforts to defeat lung cancer, champion for clean air for all, improve the quality of life for those living with lung disease and their families, and create a tobacco-free future. And so before I turn it over to Dr. Han and introduce her, I just want to send a quick reminder that our presenters cannot give medical advice during the webcast. And as always, we encourage you to consult your personal physician or healthcare provider with any questions you have regarding your specific medical condition. And next, I would like to introduce our featured speaker, Dr. Milan Han, who is a national spokesperson for the American Lung Association and the Chief of Pulmonary and Critical Care at the University of Michigan. After graduating from the University of Washington School of Medicine, Dr. Han completed her residency in internal medicine and fellowship in pulmonary and critical care at the University of Michigan. She has also completed a Master's of Science degree in clinical research and design and statistical analysis at the University of Michigan School of Public Health. Dr. Han belongs to numerous professional societies, including the American Thoracic Society and the European Respiratory Society. She is also a deputy editor for the journal American Journal of Respiratory and Critical Care Medicine and serves on the editorial boards for several journals, including Thorax and Lancet Respiratory Medicine. She also serves as a scientific advisory committee member for the COPD Foundation and the American Lung Association, as well as the Global Obstructive Lung Disease, or GOLD, Scientific Committee that writes international diagnosis and treatment recommendations for COPD. Welcome, Dr. Hahn. I will turn it over to you.
Thank you so much, Nicole. It's a real pleasure to be with all of you today. I cannot see your lovely faces. I wish that I could, but I'm going to go ahead and just imagine that all of you are there. I still see patients in my own clinic. I actually used to run the pulmonary rehabilitation program at the University of Michigan. And so am used to working with probably many of the kinds of people that are on the call, whether you're a patient, interested observer, caregiver, however you intersect with lung health. As Nicole mentioned, I've had the privilege of working with the American Lung Association for quite some time. Interestingly, the very first interaction I had with the American Lung Association, and I wish I could remember what year it was, and I want to say it might have been back in 2004. Was when the local chapter for the American Lung Association was putting on a women's lung health conference, actually. And so I have a very long history of working with the American Lung Association on women's respiratory health issues specifically. We actually have a women's respiratory health clinic at the University of Michigan, and I also take care of patients with lymphangioliomyomatosis, which is a very rare lung condition that only affects women. But for today's call, I think we're all probably aware that March is Women's History Month. It's sort of Women's Month. Yesterday was Women's Day. And so I think it's kind of fun and rather fitting that we should be focusing on women's respiratory health today. So in thinking about how I could craft a hopefully interesting talk for all of you today, knowing that the backgrounds are really different and the issues that each of you are facing is probably different, I thought we could talk about some of the more common lung diseases and how they might be different, or some of the specific considerations that I as a lung physician think about when I think about women's respiratory health. We can talk about other things that I think are important for women's lung health in general. And then at the end, I'd love to open it up for questions and just hear what's on the mind of all of you. So those three common conditions that I'm going to spend a little bit of time on today include COPD, asthma, and lung cancer. So Nicole, if you could go ahead and advance the slide for me. Okay, so the first thing that we're going to talk about is COPD. So COPD is actually the disease that I probably study the most and see the most. It used to be thought of very much as a old man's disease, and we're really coming to realize that this is absolutely not the case. We see many men and women with COPD. One of the questions I often get is, what is COPD? And I think that can be confusing for a lot of people because it actually encompasses several different abnormalities. So one of them is that the lungs, the air sacs in the lungs can break down, and we call that emphysema. And then the airways in the lungs can also become thickened and inflamed and create excess mucus. COPD is usually thought of related to a noxious exposure. Now, often that's tobacco smoke, but it may not be. And in fact, up to 25% of patients with COPD have never smoked. And believe it or not, the majority of those individuals actually are women. So we as pulmonologists define COPD based on having a classic pattern on breathing tests where it's hard to get your air out, and we see this sort of classic pattern. But again, it's important to remember that, at least globally speaking, there's a lot of things that can contribute to developing COPD, not just tobacco smoke, and that's particularly true for women. If you could go to the next slide for me, Nicole. So, why should we care about COPD? The American Lung Association, and I believe it's actually still available on the internet, a couple of years ago, did a kind of nice, a really nice, I guess, sort of publication called Taking Your Breath Away: The Rise of COPD in Women. And you can still find that on the internet if you're interested. But some of the information, I actually helped the American Lung Association put that together. And some of the information that I'm going to share today actually comes from that original report. So, why should we care? Well, there's millions of women in the US with COPD. I suspect there's more than 7.5 million at this point. Believe it or not, getting at that figure is actually really hard for a couple of reasons. Unfortunately, only about a third of people in the United States who get a diagnosis of COPD have actually had appropriate lung function testing. And so we think that there's a lot of undiagnosed people out there as well. So trying to figure out not just who has COPD, but also that appropriate gender mix, when we also know women are less likely to be appropriately diagnosed, is a really hard thing to kind of to get at. So I suspect that 7.5 million number is probably low. Well, we also know that of those women, there's at least a million ER visits a year, millions of office visits, and billions of dollars in terms of both direct medical costs as well as what we call indirect medical costs. So that's everything from the amount of time that you lost going to work to the time your caregiver had to take off, et cetera. Now, one of the things that I think maybe people would be surprised to know is that nearly twice as many women die of COPD in the US every year um, than die of breast cancer. But we hear about breast cancer so much more. And why is that? And I think, unfortunately, there has been some stigma that's been associated with COPD because people often think of it as a smoker's disease. And I think that is something that the American Lung Association has been fighting really hard to break. I don't think that there's any disease where there isn't, except for some genetic ones, where there probably isn't some environmental component, whether we think about heart disease or diabetes or liver disease, where, diet or habits probably play into it to a certain degree. So I think in the end, it's a little less helpful for us to think about our approach to diseases and funding for diseases and the amount that we care about diseases sort of based on that metric. But I do think that, unfortunately, lung disease in general and some of the research has been relatively underfunded. Can you go to the next slide, Nicole? So in thinking about how COPD might be different between men and women, I think first about differences in who has it, how they might get diagnosed, whether they die, what the disease looks like, what that patient experiences, and then also, does it matter in terms of how physicians think about diagnosis and treatment? So can you go on to the next slide, Nicole? So these are just some of the few things that I'm going to just touch on. And I will admit there's probably more research that's been done with respect to gender differences in COPD than some of the others. So I will be spending a bit more time on COPD than some of the other diseases. But again, we can open it up for questions at the end. So one thing that's interesting is that if you look at men versus women, the number of people in the US that have COPD is probably, similar between men and women. But when we look at it by age group, we have a lot of younger women with COPD. And so, relatively speaking, I think that's really important. I think that's something a lot of physicians don't realize. And when we think about the personal impact of the disease on people who are still of a working age, maybe, a mom running a household, et cetera, that means that the personal impact of this disease on women might be, potentially even greater. One of the other concerning factors is that when we look at just personal income for men versus women as a percent of the overall COPD patient population, we see that a higher percentage of women are in the lower income brackets relative to men. And that really matters for a lot of reasons. It matters for getting access to care, for, insurance, being able to afford medications, being able to take time off work to get appropriate care, et cetera. So I think that's another place where this concept of health disparities, particularly when it comes to women in COPD becomes important. Can you move on to the next slide, Nicole? Okay. If we look at smoking in the United States, and we look at who's smoking and who's dying, I have men here in blue and women here in orange, and you can see that overall there's slightly few, overall as a percentage, perhaps less women who have smoked, but the deaths for women are really really relatively going up. Now, interpreting some of this data can be a little bit challenging. One of the interesting things is that men are actually a little bit more likely to die they're a little bit more likely to die of certain diseases earlier, like they might be dying of heart attacks earlier, which means women are living longer to then potentially die of their COPD at a later date. So some of this data can be a little bit confusing, but essentially, what it shows us is that over time, while men were sort of the first ones to start smoking back in the early 1900s, women picked up. We're now roughly equal with maybe a few more men than women, but then the deaths really start to pick up, in a sort of appropriate lag phase. But as you can see, while men have flattened, women unfortunately are still in sort of this exponential phase with respect to an increase in overall deaths. Can you go to the next slide, Nicole? This is sort of that similar thing where, the overall number of deaths we see for women with COPD now sort of outstrips men. And I wouldn't necessarily attribute this to COPD necessarily being more deadly. I think, again, there's some relationship here between dying of other things at an earlier age and living long enough to die of COPD. But I think some of this kind of crossover also relates to the fact that we just have a lot more women with COPD than we had, say, 40, 50 years ago. Can you go to the next slide, Nicole? Okay, I think this one either got cut off or has a build. Just keep clicking through it maybe one more time. Okay, so interestingly, there was a study, and granted it was about 20 years ago now, and there has been a follow-up study since then, but they gave a group of physicians in North America as a little hypothetical scenario and said, you've got this patient that's got shortness of breath, and what would you do? Would you, and they kind of walked them through the workup, including breathing tests, et cetera. And by the end, if the hypothetical patient was male, more of those patients were likely to get appropriately diagnosed, whereas a smaller percentage of women were likely to get appropriately diagnosed. When you gave physicians the information on the breathing test, they were more likely to get the diagnosis right. The problem or the concern that I have is, a lot of physicians just aren't getting the breathing test. And so I'm just looking here, there was a comment in the chat about asthma. So this is true. Asthma is more common in women in adulthood than it is in men. There probably is some overlap between asthma and COPD. This can be confusing sometimes for physicians to sort out. And unless they really do a good history and they're getting pulmonary function testing and sometimes even a CT scan, to be honest, to figure out which is which, or to understand that the patient may have both, I think there is some concern for misdiagnosis in patients. And that's why it's so important that we, from the American Lung Association side, really push and advocate and educate providers that they really need to be doing pulmonary function testing. And that's why it's also really important for people on this call as the lay public to become armed themselves with information to know when you go back to talk to your doctor, hey, I really, if it hasn't been done, I really do need a pulmonary function test to understand what's going on. Can you go on to the next slide, Nicole? Oh, okay. So there may also be There may also be differences in what I'm going to call the experience of the disease between men and women. I mentioned that women tend to be younger when they get COPD. They also, when you compare two patients with the same level of lung function, women tend to be more short of breath. There are multiple studies now that also suggest women are more likely to have flare-ups or exacerbations of their disease. They're also, unfortunately, also more likely to delay seeking care in emergencies, end up using more healthcare resources, and also have higher rates of anxiety and depression. And so I didn't mention it on the slide, but women are also more likely to access information in different ways than their male counterparts. Believe it or not, they're more likely to utilize internet-based resources. I'm doing a quick scan of the chat to see if I can figure out if we have more women versus men on the call. That might be something kind of fun to look at, but the literature would suggest that we would be more likely to have women on this call than men, that this is the type of activity where women would seek to, this is a place that women might seek to get their information from. Can you move on to the next slide, Nicole? So, I'm just going back to the chat here for a second. Someone had asked, can you, for instance, why lung issues are more prevalent in women than in men? And we do not fully understand this. So I think there's probably a lot of things. So let's think about smoking. When we think about smoking, women tend to be smaller. And so for just a single cigarette smoked, it might be a higher dose for women, just because their lungs are smaller than for men. That's one possibility. We know that just differences in hormones and disease biology will influence how the body is able to metabolize some of the things in cigarette smoke, and that could also play a role. Similarly, though, for air pollution. So there are all sorts of factors in the home and in the environment that can also contribute to poor lung health. And that might impact men and women differently for a variety of reasons. So women, for instance, who are hairdressers or nail technicians might have chronic exposures to certain things that would irritate the lungs. Even in the home, women, for instance, might be, I'm not trying to stereotype here, I'm just speaking historically, might, for instance, be more likely to come into contact with cleaning products or other hazardous chemicals within the home. Men, for instance, might have, other exposures from construction work or something like that. We don't fully understand how the unique biology of women, whether that's hormone, estrogens, et cetera, might kind of alter how the body responds to some of these pollutants. It's not as much of an issue in the United States, but interestingly, it still is. So there's a type of COPD that can be related to what I'm going to call chronic biomass fuel and smoke exposure. Now, when we say that, a lot of people think that is often referring to cooking over an open fire, which is more likely to be seen in developing countries. But there was a study that was done in Canada a few years ago, and they found that for women in particular, exposure to biomass fuel was a risk factor for COPD. And so it's funny because when I read that, I actually asked the first author of the study, I said, I'm confused. What biomass fuel exposure do you have in Canada? Are these immigrants that you interviewed? Or I was very confused. And she looked at me, she said, no, I'm talking about wood burning stoves. And then it just sort of dawned on me. I mean, I grew up in Idaho where it was very common to have a wood burning stove in the home as an accessory source for heat in the winter. And I think there's actually a lot of homes in North America where that's the case. We could have a whole separate discussion on that. But it may be for a variety of reasons why, it's possible women are just either more sensitive or just the way that is in the home, or, just to have, we don't fully know why women in particular, at least in North America, would be more sensitive, but there certainly is that relationship that's been demonstrated, at least in one Canadian study. So we don't fully know why women would be different, but it is an active area of research. And what I would say, generally speaking, is it's probably some combination of social factors, environmental factors, and biological factors. Can you go to the next slide for me, Nicole? All right, so this is just, yeah, this is just sort of me expounding on the certain things that I just mentioned, that it might just be exposures, it might be dose, it might be how women metabolize things, etc. Okay, can you go to the next slide? Okay, I'm going to go on to asthma. So one of the things that makes asthma different from COPD is we typically don't think about COPD as asthma as having emphysema. So emphysema is that destruction of the air sacs. Asthma is primarily focused just on the airways, although on a breathing test, they can look pretty similar. One of the differences, though, is that usually with asthma, if you give medication such as inhaled steroids, the inflammation tends to be reversible and the lung function improves significantly. Whereas in COPD, you see less lung function improvement with medications. But sometimes that can be kind of gray. You have some improvement, but not normal. And then it can, and maybe someone has a mixed smoking history, and then it can be really confusing. So sometimes it's difficult for doctors to completely sort the two out. But asthma is thought to be chronic inflammation of the airways. It can be due to a variety of things. We often think about it as being related to allergic exposures, but not always. It can be related to smoke, air pollution, mold, chemicals. And asthma often is made worse by allergens, but it can be also made worse by other things such as infections. But again, it's also confusing because some of the symptoms that we see with asthma can be very similar to the symptoms that we see with COPD, including wheezing, coughing, and chest tightness. Can you go to the next slide, Nicole? So what's interesting is that, back up. Is that actually the next slide? I thought I saw another one. Okay, that one. Okay. So what's interesting is that and I have a son with, I've been hesitant to call it asthma, I'm going to call it asthmatic tendencies, but what's interesting is that boys are actually more likely to have asthma than girls. And this is probably due to a variety of factors. The lungs of girls actually develop faster than the lungs of boys. The girls are more likely to, for instance, they're just more developed at the time of birth. And I think due to differences in growth rates, boys just are more likely to have asthma in childhood. But as children get older and we start hitting puberty and moving through to the teenage years and into adulthood, we see a reverse in that. And women tend to have much more asthma in adulthood, and in particular, really severe asthma. So you can kind of just see on these graphs here, sort of what happens. Everybody kind of goes up over time, but for men, it just kind of evens out as they get older, and particularly for young women, it really does tend to go up. Can you go to the next slide, Nicole? I thought I had one more asthma slide. Was there? Okay. All right. Sorry. Okay. Yes, this one. Okay. So the other, so this just shows that what I just showed you, essentially for boys, it kind of drops. And then for girls, it kind of, it tends to really go up. And we don't really fully understand why women have more asthma and have more severe asthma than men. We don't fully understand it. Is it that women somehow, we do think that there is a hormonal component. So there is more evidence for a hormonal component for asthma, I would say, than for COPD. And so that could be part of it. Again, it could be other, types of allergens and household exposures, for instance, that women might be more likely to be exposed to than men. We don't fully know. All right, I think we can move forward to the lung cancer slide, Nicole. Okay, there you go. All right, so lung cancer is the disease where there's also been a lot of questions as to whether there might be differences between men and women. I have on the right-hand side of the slide just a quick pictorial of what are the most common cancers in men versus women, just not by death, but just how common are they? And so for men, you can see we've got prostate cancer, lung cancer, colorectal, urinary bladder, and melanoma. For women, breast cancer, and that's in part probably why you hear about a lot about it, followed by lung cancer, colorectal, endometrial uterus, and then thyroid. However, it is important to note that many more women, okay, so listen to this. More women, lung cancer kills more women than breast, uterine, and ovarian cancers combined. So while more women get breast cancer, lung cancer is more deadly. And I think that's a fact that a lot of people don't realize. So when we talk about lung cancer, what we're really talking about are cells that go rogue. They don't normally, the cells are supposed to behave. They might divide once and replace themselves, but they're not supposed to go crazy and accumulate. And when we have cell cycle inhibitors that keep them from just dividing infinitely, sometimes those checks get turned off, and cells can divide too much, they invade, they go to other parts of the body. That for lung cancer, we really have two major subtypes. One's called small cell, one's called non-small cell. One of the other interesting things as it relates to women and lung cancer is that women with lung cancer are actually more likely to be non-smokers than men. So there probably is some difference with respect to the biology that's going on for women as opposed to men with just even, getting lung cancer. Can you go to the next slide, Nicole? So this is something else that I think is interesting, but also concerning. So I mentioned, in general, smoking for men has probably gone down. Unfortunately for women, it's kind of gone up to kind of meet men, at least in the 70s. Then everybody tends to have been smoking a little bit less. But if you look at what's happening for lung cancer with men, it's really going down, and it's going down similar to the rates at which smoking is falling. But for women, lung cancer just seems to keep going up. And I don't think this is data from the UK. I don't think we fully understand that. And it may be that women are living longer to die of lung cancer instead of something else. I don't know. Statistics can always be a little bit confusing, and not always the right answer isn't always obvious. But I think it is really important to note from an advocacy and from a funding perspective that lung cancer is a huge issue for women. You go on to the next slide, Nicole. So this actually, I think maybe my last slide. I kind of wanted to keep it short and give us lots of time for discussion. But I kind of wanted to bring this all back home and just spend a minute thinking about what does this mean for you? What does this mean for women in particular? Some of you may know I actually recently wrote a book called Breathing Lessons, A Doctor's Guide to Lung Health. And in the book, one of the things I kind of realized was that we spend a lot of time talking about lung disease, but we don't really spend a lot of time talking about lung health. And why is that? We spend a lot of time thinking about heart health or other kinds of health, but why don't we actually spend a lot of time talking about lung health? And I think there actually are a lot of things that people could be doing proactively within the home that we just haven't talked a lot about as a medical community that could help protect not just people with lung disease, but also protect people that don't have lung disease, or prevent you from even getting lung disease, or prevent lung disease from getting worse. So some of the more obvious things include occupational and outdoor air pollution. We know that this puts children at increased risk when we have schools near busy freeways, working in dusty or dirty jobs. But sometimes that might even mean avoiding going outside on a really bad air pollution day. And then within the home, there's all sorts of sort of hidden things that can actually impact lung function. I mentioned wood burning stoves, and wanting to make sure that those are kind of, if possible, have the latest EPA certifications, or not use them would sort of be the best. Gas stoves, I have a gas range, but running I try to run the hood whenever I'm cooking, even if it's not something that's particularly smoking. Radon is a huge cause of lung cancer in the United States, and every home needs to be checked for radon. Cleaning products. There's there's new lists of EPA sort of certified cleaning products, and just being really mindful of I in general, since the pandemic has started, have tried to just be more mindful of what I'm breathing in. Just, we've all got masks around more. And so now if I'm going to be cleaning up something dirty in the home, my garage, my basement, I'll just throw on a mask. We would wear garden gloves into the garden, but we often don't think about doing that same thing for our lungs. And yet with our hands, we can wash them. The lungs do have a mechanism for trying to clear themselves, but it's not quite the same as being able to wash your hands in the sink. So we just really have to, I think, all kind of be mindful. And lung cancer screening is now something that Centers for Medicare is now paying for. Well, they were paying for, but they've just broadened the inclusion criteria, so now it's down to 50. So that's something we should all be mindful of. And then there's actually some interesting data to suggest that exercise itself may actually have anti-inflammatory and protective effects on long-term lung function. And in fact, people that achieved and maintained high levels of fitness early in life had the best lung function later on in life. And so I know pulmonary rehab is something that we all talk about for patients with chronic lung issues, but the benefits might be even more, I think, than we had initially thought. So I think, Nicole, that is my last formal slide. I see we're getting some questions into the chat, and so I'd be happy to start working through the chat questions if you'd like. I think, did you have some slides on additional resources here, Nicole? Did you want me to? Okay, I can go ahead. And so if people are interested in additional resources, that obviously lung.org/community, there's helplines, there's lots of information on the American Lung Association website about how to quit smoking, about also there's all sorts of stuff, all that stuff I mentioned about pollutants in the home, all that kind of thing. That's all on the American Lung Association website. Can also, the Better Breathers Network also has more information. If you're not a member, I encourage you to join. In the old days, we had in-person meetings, but I think, at least at the University of Michigan, we're moving to more and more virtual meetings during the pandemic. So I guess, Nicole, unless you have another suggestion, I'll just head to the chat and start looking at some of I tried to address a few of the questions, but I think there's some that I didn't get to. So let me look at this. So, okay. One question here is, can you explain the difference between bronchiectasis and COPD? They seem so similar. I have bronchiectasis and hyperinflated lungs along with MAC. Could this be considered COPD? Okay, so this is a really good question. So COPD refers specifically to history of some kind of noxious exposure, a kind of a fixed abnormality on the breathing test. And usually usually these patients have some degree of emphysema on a CAT scan. Some might have a little, some might have a lot, and some degree of airway wall thickening, often that we can also see on a CT scan. Bronchiectasis refers very specifically to a thickening and dilation of the airways. And we can actually see, so it's really more a radiographic feature. It's associated with excess mucus production. A lot of times these patients have a lot of infections in their lungs because what I'm going to call the ciliary escalator or elevator in the lungs that kind of pushes stuff out, it gets broken. And so, believe it or not, we can see bronchiectasis with asthma. I can see bronchiectasis with COPD. I can see bronchiectasis with cystic fibrosis. And sometimes we see bronchiectasis and we're not sure what it's due to. It can be due to genetic factors. We can see it sometimes in association with chronic infections like MAC. But we can also see all of that with everything else. So I can sometimes see asthma along with MAC, along with bronchiectasis. So the bronchiectasis piece really specifically is getting at just how bad that airway abnormality is. And if it's bad enough to be, kind of show some dilation, on the CT scan. If it's bad enough for you where you've got chronic, just copious amounts of mucus production every day. The reason why it matters, though, is that regardless of whether we don't know what's caused it, whether it's whether we're seeing it with asthma, whether we're seeing it with MAC, whether we're seeing it with COPD, the reason it matters is that there may be very specific treatments that can help patients with bronchiectasis, where we really focus on mucus clearance, whether that's like a cappella devices or even in some cases like a smart vest, where we really focus on, and also breathing treatments where we really focus on how to get the mucus up. And obviously if MAC is involved, then that's a whole nother set of very specific antibiotics that we would use. So sometimes it's by itself, but sometimes it's actually a feature of other diseases. So I hope that's helpful. Can anxiety trigger a flare-up?